The blood continually circulating through the human body exerts pressure on the walls of the blood vessels. While the arterial system is characterized by relatively high normal values of between 120 and 80 millimeters of mercury of pressure, the pressure in the pulmonary blood circulation is considerably lower, in the range of 8 to 25 millimeters of mercury of pressure. If the hemodynamics are disturbed and pressure exceeds these normal values, particularly in pulmonary circulation, serious health risks are the result. Pulmonary hypertension, a disorder defined as above normal pressure in the pulmonary arteries, affects people of all ages worldwide. This severe and life-threatening disease is accompanied by a markedly decreased exercise tolerance and a distinct decline in quality of life for patients. The most common symptoms of PH include shortness of breath with physical exercise, fatigue, dizziness and fainting, all of which are worsened by exertion. Pulmonary hypertension can lead to heart failure and death. According to the World Health Organization Dana Point classification, taking into account the underlying causes, there are the following 5 different types of pulmonary hypertension. Pulmonary arterial hypertension, pulmonary hypertension owing to left heart disease, pulmonary hypertension owing to lung diseases and/or hypoxemia, chronic thromboembolic pulmonary hypertension, pulmonary hypertension with unclear multifactorial mechanisms. Because of a lack of treatment options for most of the multiple disease subtypes, the prognosis for patients suffering from pulmonary hypertension remains poor. Currently, existing drug treatments are indicated solely for pulmonary arterial hypertension, which accounts for only a small portion of overall PH patients. Fortunately, the management of PAH has evolved significantly over the past decade. Hemodynamic measurements taken with a right heart catheter mark the gold standard for diagnosing pulmonary hypertension. Right heart catheterization is employed to clarify the following questions. Does the patient have pulmonary hypertension? To what extent is PH developed at rest and with physical exertion? Which type of PH does the patient have? Pre-capillary or post-capillary? Can latent or manifest right ventricular failure caused by PH be established? The right heart catheter is the most important diagnostic tool for pulmonary hypertension and, given a thorough introduction, not complicated to use. It is the only device capable of measuring a number of otherwise inaccessible hemodynamic parameters. Its workings are based on the principle of communicating vessels. The rhythmical changes of the blood pressure values in the heart are transmitted via the liquid inside the lumen of the catheter to a measuring device outside the body. Careful leveling of measuring device and heart is essential to obtain correct pressure values when using this method. A right heart catheter consists of catheter with several different lumens, inflatable-deflatable balloon tip for flow direction, thermistor, pressure transducer, computer for measuring and displaying obtained data. One function of the balloon at the tip is to guide the catheter to its desired destination. After the balloon has been inflated, it is taken up by the venous bloodstream and flow directed to and subsequently through the right side of the heart. On its way through the heart to the pulmonary artery, it measures pressure in the right atrium, the right ventricle, and the pulmonary artery itself. Additional hemodynamic parameters can be calculated from these direct invasive measurements taken with the catheter. Before the right heart catheter can be inserted into an appropriate vein, several preparatory steps have to be taken to ensure the RHC's working order and the correct positioning of the patient. The measuring instruments have to be calibrated following the manufacturer's guidelines. The inflatable balloon at the tip of the RHC must be checked for potential damage and air leakages. This can be done by immersing the inflated balloon in a sterile solution. After insertion, a rupture of the balloon during inflation would cause air embolism. With the patient in a supine position, the transducer must be placed at the height of the right atrium for zeroing. The zero reference point should be determined with care using a thorax caliper rule. Strictly aseptic conditions, in accordance with institutional policy, must be maintained at all times when handling the right heart catheter. Anatomically, there are several potential passageways to the heart for the RHC. It can be inserted into the vena subclavia, vena femoralis, vena mediana cubitis, or into the vena jugularis interna. Often, the right internal jugular vein, as the most direct route to the heart, is chosen for introduction of the catheter, also because of ease of identification and accessibility. The skin at the site of insertion is disinfected and a local anesthetic applied. The right internal jugular vein is punctured and a guide wire inserted into it. After the puncture site has been enlarged by making a small incision in the skin, the dilator and the introducer sheath are threaded over the wire into the vein. Then the dilator and the guide wire are removed, while the introducer remains in the right internal jugular vein. Before the catheter can now be inserted, all of its lumens have to be flushed with heparinized saline, and the distal lumen has to be linked to the pressure transducer. Now the catheter can be carefully inserted through the introducer sheath. When the tip of the catheter has been advanced about 15 to 20 centimeters, as far as the vena cava, the balloon is inflated with about 1.5 milliliters of air. This is done to enable flow direction of the catheter towards the pulmonary artery. During placement of the RHC, its progress must be monitored on the computer. The position of the catheter's tip is reflected by the typical pressure curves displayed. The electrocardiogram should also be continually monitored during the insertion procedure to detect potential complications. Synchronization of pressure curves and ECG is also necessary to interpret the measured values. Before each measurement, the RHC has to be flushed with physiological saline solution to avoid clotting in the catheter lumen and to ensure correct pressure readings. Also, before each measurement, the correct position of the transducer system should be checked again and the transducer zeroed by opening the stopcock. Once the RHC has been placed and is zeroed, direct invasive measuring of various hemodynamic parameters becomes possible. The reading and recording of their values is carried out at rest, at end expiration, and in synchronization with the electrocardiogram. The first value measured and recorded in millimeters of mercury of pressure is the mean blood pressure in the right atrium of the heart. When the tip of the catheter reaches the right atrium, a characteristic waveform is displayed on the monitor, confirming the correct position of the catheter's proximal lumen. Measurements of RAP mean are taken with the balloon deflated and at slight expiration. The normal value for mean right atrial pressure is about 4 millimeters of mercury of pressure. Values of more than 8 are considered pathological. After the tip of the catheter has been allowed to float further with the bloodstream through the right heart into the pulmonary artery, the balloon is deflated again and 3 pressure values can be established. As before, the correct position of the catheter is confirmed through monitoring the typical pressure curve for the location. The 3 pressure values measured here at end expiration are the systolic, diastolic, and mean blood pressure in the pulmonary artery. Before the measurements are performed, 0-point calibration is repeated. Values markedly higher than the physiological ones point to pulmonary hypertension. The next measurement is that of the pulmonary capillary wedge pressure. Even though the catheter never reaches the left heart or the pulmonary veins and capillaries, it is still possible to measure the pressure values in these vessels with it. For taking these measurements, the RHC makes use of the fact that pressure values in the left ventricle, the left atrium, and the pulmonary veins and capillaries are all at the same level at the end of the diastole. On reaching the confirmed pulmonary capillary wedge position, the balloon is inflated slowly to temporarily close the medium-sized branch of the pulmonary artery. The pressure value measured now is the pulmonary capillary wedge pressure, and its typical waveform appears on the monitor. 6 to 12 millimeters of mercury of pressure is the normal range of physiological values for PCWP. Higher values than 20 are pathological. All these measurements are taken at end expiration. The balloon should be deflated again after 1 to 2 minutes to avoid rupturing the vessel and infarction of the lung. If the patient suffers from pulmonary hypertension, wedging should not exceed 10 to 14 seconds. After deflation, the displayed curve returns to that of pulmonary artery pressure. Cardiac output is an important parameter influencing blood perfusion of the organs. To establish its value, the thermodilution principle is employed. After the correct position of the catheter's proximal lumen has been confirmed, 10 milliliters of ice-cold physiological sodium chloride are injected. The speed at which the cold liquid is diluted by the bloodstream depends on cardiac output. From the temperature measurements carried out over time at the tip of the catheter, CO is calculated by the cardiac output computer. To get an exact mean CO, measurements are carried out 3 times. This number should be increased to 5 in cases of atrial fibrillation. Directly before the cardiac output measurements, systolic and diastolic systemic arterial blood pressure and also heart rate are recorded. These are later needed to calculate other hemodynamic parameters. If more than 3 measurements of CO should be necessary, systemic blood pressure and heart rate have to be taken again. A typical cardiac output value should be about 5 liters per minute for a man and 4.5 liters per minute for a woman. The normal range for an adult is between 4 and 8 liters per minute. Another parameter that can be obtained by a modified thermodilution method is the ejection fraction of the right ventricle. The RVEF indicates the systolic pump function of the right ventricle. It is measured in percent, and normal values are between 40 and 60. Another parameter used to evaluate tissue oxygenation and obtained by means of the RHC is the mixed venous oxygen saturation rate, which is measured in percent. The blood for the determination of the mixed venous oxygen saturation rate is taken from the pulmonary artery. The first 2 milliliters of blood collected are discarded to achieve exact measurements. Further hemodynamic parameters can now be computed from the measurements that have been taken with the RHC. These include pulmonary vascular resistance, systemic vascular resistance,